I'm Yoni Harif from AISAP. This is our first webinar from the AISAP webinar series. More to come. We'll share it in a minute. We'll kick off our webinar focused on POCUS and AI. And we have here our two speakers. In a minute, you'll get a chance to hear from them. First of all, just a quick word on what is AISAP, what we focus on. So AISAP provides an AI platform that helps any POCUS use from beginning to end. So we help from image acquisition all the way through diagnostic, AI-driven diagnostic assistant, and then all the way to billable reports, integration with your EMR, and QA as well, and much more. This is going to be a fun session. Our first focus is on emergency department, primary care, and internal medicine use of POCUS. This is going to be a real case study discussion. We're going to bring up cases, talk through them. You'll see different loops and images and how the AI examines them. So it should be fun and interactive. So without further ado, I'm going to hand it over to Dr. Klempfner and Dr. Guttman to introduce themselves and get us started. Thanks, guys.
Thank you, Yoni, so much. So I'm Klempfner Robert. I'm a cardiologist in Sheba Medical Center, a 2,000-bed hospital. Fell in love with POCUS and with technology, and I'm the Chief Medical Officer for AISAP. And together with me is Dr. Guttman. Introduce himself.
Hey everyone, thank you all for coming on this Tuesday to talk about one of the new favorite topics, AI, and my obviously favorite topic, point-of-care ultrasound. I'm an associate professor of emergency medicine at Emory University. I am involved nationally and internationally in teaching and consulting at POCUS. I founded Peachtree POCUS, which does consulting and education regarding point-of-care ultrasound. And obviously AI is becoming a big part of it. So I'm really excited to be here and to talk about this topic and be the inaugural guest on the AISAP webinar. So thank you all for coming, and thank you to the whole AISAP team for inviting me.
We thank you. So I think the main question I would start with would be, you've been involved in POCUS more than 15 years, and you have a very wide perspective. POCUS has so many potentials in bedside diagnostics, seeing inside the body, right? This is what the stethoscope should have been, right? The scope is to look inside, but stethoscope you can only hear. So the POCUS can see, and the ability to see is outstanding. So where do you think that POCUS is today? What's holding it back, and what's accelerating its reach to other specialities and fields?
Yeah, so it's definitely ingrained in part and parcel with emergency medicine, but it didn't come about overnight. It's taken 20 plus years to get to the point where it was first being introduced as we're going to do the FAST exam as part of the trauma evaluation. And when I was in training, we just had one curvilinear probe because that was the only thing we were learning initially was the FAST exam. And then to develop going along where in my first POCUS course, the emergency medicine was expected to just do some basic cardiac and very basic aorta, first trimester pregnancy, and FAST exam. So just 4 indications was my POCUS rotation was about essentially 4 to 5 indications. And this was over 15 years ago, a little bit more. So it's, and then to develop to this now where emergency medicine residents are learning more advanced cardiac scanning, lung scanning, gallbladder, aorta, everything, eyes, DVTs, you name it, to the point where it's becoming ingrained, and that in the workflow they'll say, I did this POCUS on this patient with shortness of breath, and they had B-lines, and they had all, their heart looked like this. So it's taken time to come, and so emergency medicine has really been the leader, but it takes time, and so. Family medicine has recently started, as some of you know, they just made it part of their residency requirements. And so they're starting now where emergency medicine was 15 years ago. Internal medicine is kind of the same way, is there starting and going, but it's been picking up with speed. It's been really exponential as time has gone on. So I expect that exponentiality, if that is a word, to increase as time goes on and as technology becomes more comfortable, becomes more portable. But the main thing really holding it back is education. Is people who don't, they haven't learned, especially in family medicine, internal medicine, and other specialties, they didn't learn as part of residency training. They've established their practice without the use of POCUS, and so now this technology comes along, and it can be a little bit difficult to integrate new technology, especially for experienced physicians. I think a lot of them know that it's a great technology, and that it's something that would be a benefit to their practice, but there is a barrier to implementation, especially when they're already used to things already. But as it has become ingrained in the house of medicine, and as medical schools start to teach point-of-care ultrasound, give transducers to and portable machines to their students who start using it, there's going to be a ground-up swell of residents coming in who are using ultrasound, who will then become attending using ultrasound, who will then be teaching their trainees how to be using ultrasound. And in 15, 20 years, or as things go, or maybe even less, hopefully, it's going to be just like the stethoscope. It's going to be part of medicine practice. It'll be the palpation and auscultation and those parts of the physical exam, plus the insination part of ultrasound.
Do we as physicians actually need in situation where the time is very limited, right? Let's think about the ED scenario, critical care scenario. Are we the ones that will be doing the scanning, or will be just doing the interpretation? Because I don't do my ECGs, right? I don't take the blood tests. I interpret them. So what do you think the future in that aspect is?
Yeah, I think that's a great question, and it delves kind of nicely into the AI capabilities and its ability to help education. I think this is going to be something where it's possible that, and some companies and others are working on having those who are less trained do the ultrasound, even interpret it or send it to interpretation to a physician or someone who's more trained to interpret it and know how to incorporate that into their medical decision making. But I can certainly, I think in the near future, I think it'll still be physicians doing it as the physicians themselves become more comfortable. But there is a certain amount of technical know-how in knowing how to move the probe around and how to manipulate it to know the right views to get. And this is certainly something that can be trained. I mean, we have the ultrasound technicians are amazing at getting at image interpretation, and there are some departments that have hired. It's not common, but have hired ultrasound technicians in the emergency department to do the point-of-care ultrasounds that get interpreted by the physician. But I definitely see a future place where I think in the near future physicians will still be doing it. But then as we go forward, nurses are already putting in IVs with ultrasound. Physician assistants, nurse practitioners are already doing ultrasound, interpreting it themselves, and these things can be interpreted by physician specialists. So I think as time goes on, just as then more the ultrasound will be democratized and be done by everyone else.
What do you think are the main incentives for driving POCUS? So better medicine, it's important, but perhaps not always enough for the large organizations. What beyond good medicine?
Yeah, so I think number one is good medicine and the ability to make diagnoses really at the bedside and really augment both your procedural and diagnostic capabilities. I mean, if I'm seeing a patient in front of me and I'm doing a physical exam and I'm using my stethoscope, there's only so much information I can get. I can't rule in or rule out many conditions that are emergent. I can't rule out tamponade. I can't, significant pulmonary edema. And even a significant PE and other conditions that can be really immediately ruled in or ruled out at the bedside. So I think first and foremost, I think is good medicine, is better medicine, and is using available technology to look inside the body and really to eliminate or confirm potential emergent diagnoses. But on top of it, from a health system standpoint, it is reimbursable. So the way we need to also think about it is that all the technology that we're using, I mean, it is a capital investment. It is something that the equipment is not, it's getting cheaper certainly with handhelds, but it's certainly not cheap. And the technology and the middleware, the POCUS managers that are used are subscription based and expensive, and there's good reason for them. But in order to build that program, you need to have something that is reimbursable. And the great thing about point-of-care ultrasound, from an emergency medicine and outpatient standpoint, is it is something that can be reimbursed. It can be submitted and to Medicare and to private insurances for reimbursement. So you're not only doing good medicine, but you're also it is financially viable. And even if it was just financially neutral, and you're saying I'm just going to make back what I'm spending, at the very least, it is and to do better medicine and for better patient safety, this is certainly something that's very that's great for hospital systems. On an inpatient standpoint, even though it's not submitted for specific reimbursement from a value basis, it decreases the need for other imaging done in the hospital, and so that saving money allows for a little bit more profit from the hospital standpoint. So it's benefit on multiple realms, even outside as technology, mostly as the reimbursement has been going down over time. This is something that is certainly at least cost neutral, but is in the right system and in the right place can be very profitable.
Excellent. And as AI is impacting everything, from the discharge letter to the ECG interpretation, how do you see AI in the field of focus? What would be the impact, and how would this human-machine interaction be accepted and change things?
Yeah, so I'm glad we got into it again, to the AI part, because this is really exciting. And the way I see AI in POCUS itself is kind of the way AI has become exciting in other parts of medicine and other parts of our lives. It doesn't do our jobs for us, but it allows us to make our jobs easier. The most popular in the hospital is the ambient listening and the note taking. I mean, notes still have to be written, but AI just allows our conversation and is a great kind of assistant to be able to write those notes, even though ultimately it's the responsibility of the physician to write those notes. And so with point of care ultrasound, what's already around and what's coming is again that assistance. So I think starting from an educational standpoint, because I like to split it into AI and POCUS into two. There's the educational image acquisition, and then there's the image interpretation. And so from an image acquisition standpoint in the education, AI and this already exists on a number of devices and software that can assist in how to, especially in cardiac, how to move your image around. So how to manipulate the probe. So you can put the ultrasound probe on the chest, and cardiac imaging can be difficult, especially the image acquisition. So it tells you, hey, you move your probe this way, move your probe that way, and so and tells you how to get the perfect view. And once you get your view, it can therefore then save an image. And so it helps bring down the barrier for education. You don't have to spend as much time practicing. When AI, you're still getting the image, and it's still up to you to make sure the image is good, but it's helping you move in the right direction. And the way I see this is allowing AI to actually do a lot of is doing at least a good amount of the education. Anyone who's in point-of-care ultrasound education will tell you that the biggest limiting factor is having faculty who are available to teach the ultrasound. Faculty experts are few and far between, especially at these big centers. People are comfortable teaching, and their time is precious. In that it's expensive to sort of bring them on, and a lot of big systems, if they're not making a big investment in it, tend to have a limited amount of people to teach ultrasound. And so what AI does, even if you're going to teach one small session to your medical students, for example, or to your residents, they can then take AI, go into and practice on each other, practice on and go into the hospital and sort of be able to use the AI to help teach them what to do. And even if they weren't going to use the AI in the future, they're going to use it now to help manipulate the probe and to tell them when they have a good image or they don't have a good image. I mean, this technology already exists. And so it allows you to use less faculty time and using AI to really help the educational process. Outside of big university, I mean, if we go even more globally, thinking about global health in low resource countries where you don't have, again, it's even harder than these big universities. Big universities have issues getting educators, all the more so in these low resource countries. So if you have AI to help teach people how to do it when you don't need that expert to come in and teach people, it really allows the education to spread. And so from an educational standpoint, that's really how I see AI. If you're a family physician in private practice and you don't have the ability to go practice on a number of patients, AI can help teach you really in your own clinic and in your own time for really a fraction of the cost as compared to an in-person educator. And so that's very briefly on education. But then from the diagnostic standpoint, there is the AI's ability to, when AI is fed a lot of images and can learn and to learn how to do measurements and how to assist with something like ejection fraction or valvular assessments, for example, in cardiac or in non-cardiac, to help diagnose pneumothorax and to help evaluate for B-lines, for pulmonary edema and other interstitial diseases, pleural effusions, et cetera, and beyond. It helps not only the image acquisition, but it does a couple of things. One, especially in the emergency department, where we're not necessarily assessing valves, it can give us those valvular measurements in basically no time at all, and let us know whether someone has any significant valvular disease. But also, not only does it help us with those kind of things, but it also helps with reassuring us that we're actually doing the right thing. It's very common that I hear from early POCUS users and even some experienced POCUS users who don't want to do it and don't want to, like, I don't want to do a POCUS because I'm afraid of that it's not going to be a good interpretation and I'm not sure what I'm looking at. And there's a real lack of confidence. Even people who know what they're doing, and I've reviewed their images, I'm like, you're good at what you're doing. You know, you're getting great images, you interpret correctly. Especially a lot of physicians in practice are not confident in their own abilities. So with AI, even if it's AI is just going to tell you what you think you already see, it's that person over your shoulder that basically says, you know, yes, you are doing a good job. This person does have a normal ejection fraction or a low cardiac contractility. And that confidence allows them to actually make clinical decisions based on what they're doing, which is ultimately why we're doing POCUS, is to help patients, and that confidence will allow POCUS to really thrive.
This is very aligned to what we're seeing. We're seeing that physicians with AI are twice as likely in a multivariant model to change management versus the same physicians with the same capabilities without AI. So AI does give you this extra confidence, extra pair of eyes, and so you can make those management changes, because ultimately we want to change something based on the things we are seeing in the POCUS exam. So this is a perfect introduction to the cases that we are now going to review. And we've selected out of many cases, a few cases that we thought were more interesting and representative. And this is actually a case that I've been involved in our organization. So I'll describe it briefly. It's a 60-year-old male smoker with established COPD being admitted with fever, dyspnea, and actually passing through the ED, and based on the fever, dyspnea, cough, having a working diagnosis of community-acquired pneumonia based on the clinical presentation and some non-specific lung infiltrates that was performed and interpreted by the ED team. And what was interesting and fortunate is that the resident in the internal medicine department, performed a POCUS. I think there was a more of a feeling that something here is more, and I think it's a good practice. And the images of the parasternal long axis and the apical 4 with the color Doppler is as you see. Dr. Guttman, what would you comment on these images?
I think I mean I think if you know how to interpret echo, you can see that there's a significant mitral regurgitation. But you know, when you're doing that, I think I personally I think every sick patient admitted to the hospital should have a screening echo, and it helps with how much if they haven't had an echo recently, you know, it helps with fluid management to know if they can tolerate fluids, but also it gives you a general sense of how their heart is doing and how well they are potentially going to recover. And if they get even sicker, you kind of know, you know, what their heart is like. I think in this case, you know, having the screening echo and finding this, which may not have been known, can certainly help down the line. Do you have any AI for this one?
Yeah, it
Yeah.
happens to, yeah, I happen to have something. So first of all, I would like to emphasize that this scan took about 4.5 minutes. And uh, the evaluation that you can see here for the MR only needs 2 clips. So you don't have to do the sophisticated measurements and evaluations that one performs in the echo lab, where we would measure vena contracta in PISAs and calculate effective regurgitant orifices and stuff like that. But based on basically 2 or 3 loops, we can generate a comprehensive evaluation of what we're dealing with. One, there's a severe MR here, right? That has to be managed very differently than the suspected pneumonia. We can see that it is also associated with mild LV dysfunction, and there is an additional mild tricuspid regurgitation, which is not that important, but the left atrial area is already enlarged. That correlates well with possibly this MR over time, dilating the left atrial area. And obviously, the management of this patient actually, the medical management was attempted, so fluid management, so reducing the fluid that he was already receiving and giving diuretics and giving ACE inhibitors, but still the MR did not significantly improve, and ultimately the patient underwent an invasive clip for this MR, and which is of course a therapeutic tool that we have now. It's not a very complex or a high risk one, like undergoing mitral valve repair or surgery. So definitely we had a good outcome in this case, and then the entire management was different.
Yeah, and I think that's great from a cardiology perspective, in saying, okay, like even finding this MR, even if it were not to make a huge difference in the patient's care in the hospital, whether if you're a hospitalist or an emergency physician, this ultimately helps the patient down the road, you know, to get that mitral valve repair, and identifying significant disease in the hospital that's potentially life limiting is something that we're doing. But I want to briefly mention how this might actually help. If this case had gone differently, in the emergency, from an emergency medicine or from a hospitalist or admitting physician standpoint, in that, you know, this patient could have had, sometimes pneumonia can be endocarditis with some septic emboli, and so, you know, especially if this patient wasn't improving, having that screening echo and finding this could have said, oh well, maybe if it made sense, depending on the infiltrates, maybe this is not pneumonia. Maybe there's an acute valvular problem because of potentially vegetation. And so in that case, it could really, you know, alter your management. And so having that screening echo not only helps with fluid management, but potentially can find significant disease. If this patient, for example, had an echo the month before that had no MR, and you were to say, okay, fine, it was relatively normal or not too bad, and you were to say in the hospital, well, he just had an echo a month ago, you know, so why do we need to do another one? Well, here's another reason to do another one: is you might have some acute valvular pathology, like endocarditis, and your pneumonia might be septic emboli. For those of you who've been practicing long enough, you kind of see these sneaky endocarditises. So this is another reason to do this echo as it comes in, and you know, so even if you don't know at all what, you know, you don't know how to interpret color, you're not sure everything that you're doing, what AI really does here is it's basically just giving you this preliminary reading that says, okay, this looks okay, this doesn't look okay, here the EF is good, the EF is bad, and here's some MR, or here the valves look fine, the right the right heart looks fine. So you have just more information that could potentially change your diagnosis. And so, like I said, these are some reasons that having that screening echo is important in the hospital. And by screening, I mean to make sure that there's nothing that's going to acutely change the management and going to affecting our fluids and our potential diagnosis. But and just AI just gives that confidence and says, like, oh yeah, I might not be that great in echo, but if I have AI help point out some of these abnormalities, I will know what to do with this. You're seeing this, you might get a comprehensive echo, where you might not have in the hospital anyway. So I really feel like, having that AI to give you that confidence that says, oh, this is looking bad, or I'm not sure what I'm looking at. Here's an interpretation, can help with downstream testing. Or the opposite, you might say, okay, well, it's very normal. I'm going to be reassured. I might give this patient a little bit more fluids. They might be able to get out of the hospital a little bit earlier. They might recover faster, and helping with that prognostic and diagnostic capabilities is so important for patients being admitted for pneumonia, for sure, and any sort of infectious or cardiac process.
Great. And we have a question here I see in the chat regarding accuracy. So for MR, we have a sensitivity of 93% and the same specificity, again, 93%. And for a multi-class, mild, moderate, severe, when compared to the core lab of Mass General, the kappa score was 0.91, so almost perfect agreement. Human has to be in the loop, so it's not a autopilot, but it definitely improves the ability of the non-cardiologists to evaluate valves. And I think it's the more we'll be doing it, the more we'll get better at it. And the fact that we're looking at valves is very important, because dyspnea or fluid retention is not only LV dysfunction, reduced LVEF, or heart failure with preserved ejection fraction. These valves are there and they're important, and we need to look at them. And we have information that we're probably missing somewhere between 30 and 50% of these cases. And some of them will not get a full echo during the hospital stay. So having these cardiac POCUSes providing information within a 5-minute exam, and this AI being available within your workflow, is very important. This pops up on the same tablet. In this case, it was a Lumify. In the next case, it's a Butterfly. It doesn't matter. It has to be in the workflow. And Josh, you're an expert in workflow, but that's workflow and billing. That will be topic for another webinar, because it's a very significant, and you'll probably have a lot of things to say about it.
Yeah, if you imagine like when you get a full echo, and it's getting interpreted by a cardiologist who's giving numbers, and it's up to, it's giving parameters and they're interpreting it, but it's really up to the physician at the bedside and the primary treating clinician to decide what to do with that information. They ordered it for a reason. They get the information that they get from the echo and then say, okay, well, this is how I'm going to apply it to the patient in front of me. It's the same like any test. And so it's the same here. You get this information and then you'll decide, okay, this is what I cared about their EF. I cared about the valves, depending on, or something else, depending on what the clinical scenario is. But you get that information immediately at the bedside and do with it like you would do another test. And I think just to mention the accuracy, what's a little bit what's different than large language models like ChatGPT and so on, which is pulling from the whole internet. These are and Robert, you can speak about this a little bit more, but these are images. These are what's being fed into these AI algorithms are expertly interpreted images. So it's not pulling everything off the internet with various, variable quality and accuracy. You're taking expert read images and feeding that into the algorithm. So it's different than just pulling than ChatGPT pulling things everywhere on the internet.
Definitely.
Thank you. Dr. Guttman, I did want to introduce quickly the second case.
Yeah.
And, Robert had, Dr. Klempfner had mentioned the butterfly, which is this case right here. I'm going to try to start it again so people can see the actual motion. So in this case, it was a 58-year-old diabetes patient presenting, as you can see, came in with left-sided chest pain. But otherwise, no other symptoms. What would you say is kind of like the thought process behind this coming into, if there was this person was under your care or one of the folks that you're training on POCUS?
Yeah, I mean, what you want to anyone with chest pain, you're worried about. We talk about MI, we talk about PE, especially in the emergency department, we talk about aortic dissection as kind of those bigger ones. We talk about pericardial effusion with tamponade, and those are all sort of some of the big dangerous findings or dangerous diseases that we want to rule out everywhere with chest pain, with history and physical. And where POCUS is really pretty good at most of those things. It can look for pericardial effusions and tamponade, and it can be ruled out, pretty immediately. With pulmonary embolism, you can look at evidence of right heart strain and right heart function that can be looked at pretty immediately on the point-of-care echo. And even with an MI, you can look for, it's a little bit harder, but you can look for atrial wall motion abnormalities. And then with AI, there's actually some AI that can actually do that as well and help us with kind of strain analysis and sort of some of these more advanced techniques that you wouldn't be able to do on your own, and I wouldn't be able to do on my own, but that could kind of help with knowing if there's any if there's any evidence, especially as compared to a previous echo, of having an MI.
Right. And in fact, we can take a look at what the AI in this case was kind of seeing. And you can see the findings here. I'd be curious what you think about it. And like before, folks, if you want to jump in and ask any specific question, or maybe you would take it in a different direction, it'd be very interesting to see here. But again, in this case, we saw, obviously, as you can see, the LVF, ejection fraction coming up, right?
Yeah, and I think if you just looked at the image, just looked at the image, it actually, the EF actually looks probably grossly a little bit better than that. But I think this helps say, okay, well, maybe I'm going to take a second look at that EF, or maybe I'm going to get a different view. Or you might say, okay, everything else is actually looking pretty okay. And so if I'm not concerned with this patient based on my history, physical and POCUS, and then perhaps some blood work, troponins, EKG, the combining with the whole thing, this doesn't remove any of the usual emergency department evaluation of chest pain patients. You're still doing all the other things, but this is giving you a little bit more information that can either give you something that that needs to be acted on in the hospital, or with this person, if their troponins were fine and their history and physical didn't suggest that they needed workup for PE or dissection. Clearly, they didn't have a pericardial effusion on their ultrasound. You might say, okay, and none of these other findings are really significant enough that I need to keep the patient in the hospital. This is actually quite a reassuring ultrasound, but they do have a lower EF. So even if this person doesn't have symptoms of volume overload, their legs aren't swollen, they're not short of breath, this might be someone who I would refer, or at least when they're going to see their primary care doctor for further evaluation as an outpatient. This is really important information that the primary care physician or their internist as an outpatient, their family physician can then can send them for a comprehensive ultrasound, perhaps even finding early onset heart failure, maybe more aggressive with their hypertension management, can send them to a cardiologist a little bit sooner and actually can prevent them from getting worse and help them get better a little bit faster. So what's really, really nice about this is we're really not just thinking about, okay, how's this affecting the immediate care in the emergency department? We're going to end up discharging them if everything's looking normal, but we've found something that could potentially be harmful in the future just by having AI assist with our interpretation. So it's both reassuring and helps us a little bit down the road, while we've also used our basic point-of-care ultrasound skills to make sure that there's nothing dangerous along with the rest of our evaluation.
And we also know we are so good at treating LV dysfunction, right? And we have disease-modifying medication that reduce the chances of these progressing to severe heart failure, arrhythmia risk, and in general, all-cause mortality. We can reduce it dramatically, but you can't treat what you don't know. So it's not uncommon, right? LVEF, it's not just having a history of myocardial infarction. It can be due to many things, including cardiomyopathy or a viral myocarditis and so many other things that we encounter every day. And many of our patients are diagnosed late.
Yeah,
And
and I can move this even, I just wanted to really just move this even from the emergency department, which where I work. So move this to a primary care office, right? So imagine they weren't presenting with chest pain, they're presenting for, they were found to have hypertension in a clinic and they're seeing you for the first time, or you're managing this patient's hypertension in the primary care clinic. Now you've now at the bedside been able to find early onset of heart failure and be able to do that, all this disease modifying therapy that exists. So this is like the ultimate screening tool. And even if this is not something that you as a primary care doctor, you're like maybe a little bit facile, but this helps you really be able to screen your patients for significant cardiac disease, and to help prevent worsening of this with time. So it's really it's applicable in so many different scenarios, even in primary screening.
excellent. So I think we can move onward for the sake of time for the next case. Again, a case that I think we see a lot every day. Elderly patients coming with treatment of hypertension, diabetes, but presenting with episodes of presyncope or real full syncope. There might be during exercise, or sometimes it's not that clear, but syncope is one of the common presenting factors, and the workup is also important. And this case actually got this scan by a medical assistant that scanned and presented the scan to her ED physician working with her. And any comments on these images, Dr. Guttman?
Yeah, I mean, I think from a syncope standpoint, I'm even pull that away just from the images, but I think just from a syncope and presyncope standpoint, I mean, this is so common that we see these patients in the emergency department, and in the primary care setting. I'm sure also is patients will present after syncope or presyncope, and it gets very tough to know who needs further. Sometimes it's easy, but sometimes there's a lot of gray area that comes in, and who needs an echo, who needs to be admitted for monitoring, and these patients have long lengths of stay. I think everyone would agree who works in emergency medicine and observation medicine, that even hospital medicine, that these patients are admitted way too much. And we do a lot of telemonitoring. We do a lot of echoes on patients who are presenting with syncope. And I think our experience is we find sometimes there's significant abnormalities, but most of the time we don't find much. They stay 24 hours in the clinical decision unit or the observation unit, and then they go home. So I think that having an ability to, and what we worried about when we get an echo is really mainly the EF and valvular function. We want to make sure that they don't have a significant aortic stenosis as a cause of the syncope, as well as LV dysfunction. So that's a reason we're getting echo, and a lot of hospitals those echoes are delayed. So it takes a while, to get, in my hospital particularly, until the echo is done in red, even though they're actually quite prioritized. This could be 24 hours, and so patients are having a significant length of stay. Whereas if we can do those valvular assessments in the ED or early in the observation unit, we can actually prevent the patients from staying for longer. And actually, that's one of the more exciting things for me with AI in this scenario in syncope and presyncope, is to be able to really risk stratify our patients. If we can have a valvular assessment really at the bedside that says, okay, their valves are okay, we can discharge them earlier. So and that's what I think, and that workflow aspect, we can keep patients out of the hospital. We can do less testing and less echoes, and leave the comprehensive echoes done by cardiologists to other patients who need them, who need them, when we can potentially have this sensitive test that screens them out. So even like if you didn't know, or you just had some basic understanding of what this image is, just having AI assist with this can provide that reassurance that this patient does not have significant valvular disease, and they may be candidate for earlier discharge without a comprehensive echo.
Definitely. And the AI indeed, as you can see in the next slide, the AI highlighted that there is something that's significantly abnormal here in the valve. And this is based, again, just on two loops, the parasternal short axis loop and the parasternal long axis loop. Based on these two loops, the ED physician got information that immediately changed management. The ED physician was not expected to do any type of sophisticated calculation or measurements or Doppler envelopes and continuity equations. He frankly has no time to do this, but he needs this early warning system, say, oh, there is something significant that needs a consult here and a full echo. And obviously we know how to treat aortic stenosis. And I think aortic stenosis is huge. I think it's one of the most less diagnosed condition that is life-threatening, so it kills you. We're not diagnosing it, especially in women, minorities, underserved areas. Probably, so statistics are probably we're missing half of the patients, and we're going to see much more of it because as we live longer, the prevalence increases and it reaches somewhere between 10 and 13% in individuals over the age of 75. So it's a common condition that's age-related, it's fatal, and it needs to be diagnosed. And using the stethoscope alone doesn't work. We know that it doesn't work, but we're still continuing to do it. But now we have new options. I think screening for AS is also something that should be done in the appropriate, of course, population, because we have now evidence from a New England Journal of Medicine published just a few weeks ago that probably treating asymptomatic aortic stenosis also has significant benefit, and it's probably going to change the guidelines, the early TAVR study.
Yeah, and you all heard that from a cardiologist who was saying stethoscope is not great. And I think about us, in the primary care and emergency medicine settings, it's loud. We don't listen as well as we would like to, even as compared to cardiologists. And so, even if you're thinking, oh well, someone with this severe AS, they're going to have a murmur. Yes, but in just realistically, we don't listen as well as we would like to. I certainly see a lot of hallway patients. I see a lot of syncope patients. I try to listen when I can, but certainly it's limited. And so just being able to do that echo. Now, with this patient, what would happen with this patient in an emergency department, if they just did not have the AI associated, even if they got a pointer echo at my hospital and other hospitals, they would go to the clinical decision unit because they have exercise-induced syncope, pre-syncope. It is a little bit more at risk. They would get an echo, and then 24 hours later, we would get a read that said there is AS. But just using this, you've now cut their length of stay by 24 hours, and so that makes a big difference to the patients for staying in, because now you've admitted them to the hospital. You've got your consult faster. You're getting their workup being done a lot faster. And that's saving money, that's saving the patient time. It's so many benefits of lowering length of stay. Your metrics are going to look better. So ultimately, with these syncope patients, there's the part that it's going to reassure us. But then on the other hand, when we find something significant, we can get their workup done a lot faster. And if this was someone who you weren't necessarily going to send to the CDU, for some reason you were reassured with them, this tells you the opposite. Well, actually, this is someone I should be more worried about. So definitely hugely helpful inside our workflow in the hospital or in the observation unit in the emergency department. Very, very helpful. in these syncope patients, which we admit all the time.
Definitely. We have two questions. I'll briefly answer them. One is the AS assessment FDA approved for out-of-hospital use? So yes, it's approved for any care setting where there is an indication for the performance of a POCUS. So doesn't have to be inside the hospital. Wherever the benefit arises, it can be used, and it's approved for any physician that's privileged to perform POCUS. Interpret POCUS. Regarding another question regarding the workflow where residents is scanning, but the sign is performed by the attending. So yes, we obviously are aware of these type of workflows and we fully support them. So you can have a separate scanner and a physician interpreting, doing an initial interpretation, and only the attending actually doing this overread, or also possibly providing QA information, and only the attending has the privilege to send through our system these images and the final report, which is structured and automatically generated to the EMR. So yes.
Yeah, this can be done by learners or attending physicians or physicians in private practice. I mean, it's really something that's meant to democratize the ability to just do it. And if you're sometimes when I'm in practice, often I like doing the ultrasound with the residents because I like to teach. Sometimes if it gets really busy and they do it and they're expected to save their images, and I can review them, just on our middleware system, on our POCUS manager. And so this is great for residents, and it's great for pretty much everyone. And so that part of the workflow doesn't change.
Perfect. I think we can now jump to the fourth and final case. And Dr. Guttman, I think this is a case that you have successfly managed. So...
Yeah. So this is a case, is really something that we see in emergency medicine. That's where I work, but we see these all the time, right? So you have a case of a 55-year-old and their fever and they're altered and they really can't tell you much, right? But they're hypotensive, their renal function is worsening, they're in severe sepsis, they're actually in septic shock, right? So you start them on our norepinephrine for a patient with septic shock, and really it doesn't. This patient happened to have a UD. But this is part of our general sepsis assessment. We start them on fluids, we do the blood cultures, we do all that kind of thing. But I brought this up, and this ultrasound is fairly pretty obvious. It's very, very poor contractility. You probably don't even need AI for this one, although AI would certainly help interpret it. The reason I wanted to bring this up is really as an important screening tool in your evaluation of your septic patients. And so twofold. One is you're going to go earlier towards norepinephrine or pressors when you see that they have very, very poor squeeze. AI or not, like you're saying, okay, that heart is working poorly. It's really important that you do that screening, that echo, to make sure that you're not going to put them into fluid overload by giving them fluids. But on the other hand, you find it's someone who's not, especially if they're not improving on your norepinephrine therapy, you always have to think about sepsis-induced myocardial dysfunction, which is very, very often missed. There's no way to know what their heart is doing unless you actually look. And that's why the point-of-care ultrasound is so important. And I stress it in every sick patient, but especially in sepsis care. We know sepsis there's more and more sepsis in the hospitals. There's a ton of metrics that are looking at it, and the mortality is very high. It's probably somewhere 10%, if not more, for sepsis, so extremely high. And so it's well known that what sepsis and septic shock can do is worsen heart function. And so doing the point of care echo in this case tells you that, okay, especially they're not getting better on a peripheral vasopressor, we need to add something that is going to help that heart squeeze, and that will improve the cardiac output. So that could be something like adding a dobutamine to your norepinephrine, or switching altogether to epinephrine. But you're never going to. It's not something that you're going to know specifically without doing the echo. And if this had been done in the first place, epinephrine might have been the initial vasopressor of choice, or norepinephrine and dobutamine could have been started much earlier, and then they would have started recovering faster. So they wouldn't have gotten as much fluids as that's 30 cc's per kilo that is supposed to get, because it can put this patient into pulmonary edema. That's certainly not indicated. But second, you can start treating the spectrum of physiology that is involved in sepsis care, including myocardial dysfunction, which is why I advocate in sepsis and in sick patients, get the echo, and then you can actually you can clear their lactate faster, their renal function can get better, and they can actually improve a lot faster. So this isn't particular for AI, but if you are new for interpreting and were worried that it's like, okay, I see this is really bad, but I'm really concerned. I don't want to add another pressor. I don't want to change my management too much, because what if I'm wrong? What AI would do in this case would help confirm. You're like, okay, this looks like a really bad LV. I'm pretty sure there's a bad LV. And if you are worried about your interpretation of it, there's no AI with this image in particular, but it can help tell you, yes, okay, this EF is really bad. And you can bring yourself up in that level of both confidence and expertise to say, okay, oh yeah, no, I really need to change my management because I thought this looked bad. The AI agreed. The AI was that person looking over my shoulder that said, yeah, this looks really bad. And that together says, okay, fine. I think this is reasonable enough that I can actually change my management. And so that confidence is where AI can really be helpful.
Fascinating. A question arose regarding, do you see AI as part of the privileging or QA process because the time-consuming steps that are required currently by our faculty?
Yeah, 100%. And I think that's well, while we have the image acquisition and image interpretation aspect of it. I see a future 100% with AI QA. And I think, as you mentioned really nicely, there's not that many people who can do QA. It's expensive, there's faculty time, and it takes time to turn around that quality assurance. But if you can get an AI interpretation immediately after the scan is done, that's so much better in education. It's almost like having an ultrasound faculty there with the learners or with the physician to give that immediate feedback. QA is typically within 24 hours or within a week, and someone has to read it. You have to pay for that person's time to read it and do the QA and give that feedback. And it doesn't mean that you never need. I'm not envisioning a world where there is no actual physician expert doing QA, but I envision a world where a physician interprets, let's say, something as a true negative, and the AI interprets it as a true negative also. That's not something that a physician would need to interpret. But I envision a world that both you get the immediate feedback if you need, but also for physicians already in practice and already credentialed, that if the AI says, if the physician says, okay, this is negative, and the AI says it's positive, A, the physician can look back and say, hey, did I make a mistake? And B, that triggers a QA process where now that gets put into a QA queue. So I can see a way that in an entire health system, you can have a multi-hospital health system where QA is just done by just a couple of people, because the volume that they need to do is much less when you have AI assisting in that QA, where if there's agreement between the two of them, there may not be a reason for people to look over. This doesn't exist yet. This is a future that I'm envisioning, but I do see it really going that way as AI starts to be able to interpret more images, not just cardiac. There's lung is starting to, it has AI associated with it. When I can see vascular, aorta, everything that we're doing right now potentially can have an assistive AI interpretation. And so once that happens, then that QA can happen with AI to potentially, broaden the scope of QA and bring QA to everywhere where there isn't right now.
Excellent. Oh, go ahead.
I think we need to wrap up because of time. Just a short, very short question. If you had, what would be your top 3 other organs that other clinical conditions that you'd like to have AI that's not out there, because obviously solutions need to be comprehensive?
Yeah, I think the ones that I would love to see that already exist in some state, and there's people working on it. I think for lungs for pneumonia in particular, is something that I think pneumonia is very difficult to diagnose. Chest X-rays are often not great, and it can be difficult in the lungs. So I think if an AI can interpret a lung ultrasound, and especially if it would be possible to detect viral from bacterial pneumonia, now I'm thinking a few steps ahead. But I think ultrasound interpretation of pneumonia is something very important. But I think lung, as ubiquitous as lung ultrasound is, I think having AI there would be great. I mean, aside from cardiac, I think it would be, the other thing is ocular ultrasound, especially for optic nerve sheath diameter. As anyone who's done ocular ultrasound knows, that there's a lot of operator dependence with the angle that the optic nerve sheath is looked at in the eye to be able to tell intracranial pressure. So I think having AI be able to get that perfect angle and make that measurement will help create some will make it so that there won't be so much variability in the optic nerve sheath diameter measurements, which a lot of times that's a lot of the limitation now in those cases is having you move your probe very slightly, and your angle is a little bit off, and it changes the measurement entirely. And so I think that's something where AI can certainly be helpful. And then lastly, I think in really rural environments to have pregnancy dating and being able to pregnancy gestation, where is the baby, head down, how far along is the baby, especially when someone is not trained in that, I think is other uses for AI. But there's so much potential to help people in those scenarios.
Excellent. Thank you.
Thank you so
I think
much.
we have a few minutes left before, so please send in your questions, even if we can answer one quick one, and we'll follow up with some questions afterwards. Please reach out. So if you have anything that you saw here that kind of teased your imagination, reach out to Dr. Guttman or Dr. Klempfner. We'd be happy to facilitate that and examine your workflow, your AI and POCUS activities, and help where we can. So any other questions, feel free to send them now, and we'll address as many as we can before closing this webinar, and more to come, more webinars to come soon.
So, yeah, we
We have
have two
questions?
questions here.
Oh,
One
great.
is addressing where do we think that there will be the most impact in the hospital setting?
Where in the hospital setting is going to be the
Yeah.
most impact? Oh,
Yeah.
yeah. No, I think it helps. I think in inpatient in the hospital medicine, on the wards and in the emergency department, I think those are the two kind of main areas in the acute care management. I think that's where things are gonna have the soonest impact, which is why it's so important for hospitalists and internal medicine physicians and residents and emergency medicine to really take that on, because ultimately we can get patients in the emergency department and in the hospital disposition faster, make faster diagnoses, and making those diagnoses and is really our role rather than the specialist role. The specialist often comes in when we have an established diagnosis. So I think that's where AI to bring expert level ultrasound capabilities to the bedside that typically require testing that can take a long time to do, to take days to get echo, is really, I think, where it makes the biggest impact in the hospital itself.
Excellent. And another question is this mainly expansion of the access for POCUS, or is there a deeper change that we believe is happening in how care is delivered?
Oh, we could talk about that for an hour on our own, but I'll say it's both. And the way when I see it as both as improving the diagnostic capabilities at the bedside, improving the ability of people who aren't very heavily trained in point of care ultrasound or echo or all these other indications to be able to do it. But I also see it as bringing care to the home. I think a lot of us in medicine understand that some of the future of medical care is in the home, bringing it to patients who can't leave their home, who's better managed at home, who lack transportation issues, who live in rural or suburban environments where travel to specialists, travel to get ultrasounds done, travel to get testing done is difficult. Using AI, using POCUS and these machines that can attach to your phone, and using AI can allow someone with minimal training to be able to do more advanced assessments with the patients in the home. So, and being able to make diagnoses and referrals via home telemedicine. I mean, like having a paramedic, in a community go to a patient's home and be able to do a point-of-care ultrasound themselves, and with AI assisting in the diagnostics, and then finding something that then they can telemedicine in a cardiologist or pulmonologist or whatever specialist is needed. I think is improvement. So I think AI will help it go deeper, allows people who are already doing POCUS to expand their abilities, as we talked about the valvular assessments, but also to democratize it and bring it out in the diagnostics to the patients in their homes and in areas that are not being reached sufficiently and that are low resource at this point.
I agree. I think there is a change, and the change will come from below, from the students, right? The students, they're tech savvy, they're learning this, they want to use it. It's once you start using it, once you have the initial wins, you never forget these wins because they're large, and you're going to keep using it. It fits, right? We have these wonderful devices that are getting better and better because that's what technology does. And I think it will lead to a real management shift to the better. And I think it possibly, and there are studies out there that show that it can really save money, save unnecessary, expensive, and sometimes even exams that have X-ray or CT that can be averted.
Absolutely.
Thank you both, and thank you everyone for joining us today. We will send out a recording so you can share with your colleagues. Appreciate you taking the time, and meet you on the next webinar. Take care.